Hello everyone, I'm Dr. Alicia Fernandes, a physiotherapist with passion for helping patients reclaim their motion and live pain-free lives. Quervain Tenosynovitis is a common condition characterized by inflammation of tendons in the thumb. Patients typically present with pain and swelling and difficulty in thumb and wrist movements. However, in some cases, patients may experience referred pain and symptoms that mimic other conditions, leading to misdiagnosis. The hallmark signs and symptoms of Quervain tenosynovitis include pain. Patients often report localized pain in the base of the thumb, which can radiate up the forearm and into the thumb and index finger. Pain is usually aggravated by gripping, pinching activities such as holding a pen, turning a doorknob, or lifting objects. Swelling and tenderness may be present at the base of the thumb, where the inflamed tendons pass through a narrow tunnel called the first dorsal compartment. Patients may have difficulty moving their thumb and wrist, particularly during activities that require thumb abduction and extension, such as picking up small objects or opening jars. Weakness in thumb and wrist muscles may be present, making it challenging to perform tasks that require fine motor skills or grip strength. Diagnosing Quervain tenosynovitis is primarily based through a thorough history and physical examination. The Quervain test is a specific physical examination maneuver that can help confirm the diagnosis. In this test, the patient makes a fist with fingers closed over the thumb, and then the wrist is bent towards the little finger. If this maneuver reproduces the patient's symptoms, it is considered a positive test and is indicative of Quervain tenosynovitis. The initial treatment for Quervain tenosynovitis usually involves rest, splinting, and activity modifications to avoid aggravating movements. Non-steroidal anti-inflammatory drugs may be prescribed to reduce pain and inflammation. Physical therapy may be recommended to improve thumb and wrist mobility and strengthen the surrounding muscles. Therapeutic modalities such as ultrasound, heat, or ice may also be used to elevate symptoms. In some cases, where conservative measures are ineffective, corticosteroid injections may be considered to provide temporary relief. In severe or refractory cases, surgical intervention may be necessary to release the tight tunnel and decompress the inflamed tendons. A 45-year-old homemaker female presented to the clinic with complaints of pain and swelling in her right thumb, which has been gradually worsening over the past few years. The patient reported difficulty in gripping objects and performing daily activities like daily house chores. She has been previously diagnosed with Quervain tenosynovitis based on her symptoms and physical examination. An MRI of the wrist had confirmed the diagnosis, showing inflammation and thickening of the tendons. She was now advised by her orthopedic surgeon to do a prehab for 1 month, including ultrasound, laser treatment, and dry needling, since she was reluctant for surgery. Patient came to me with 15 days of physiotherapy done at the local clinic with the above mentioned treatment and had no relief. The patient was referred to me for pre-rehabilitation before considering surgical intervention for Quervain tenosynovitis. I performed a rough assessment including a review of patient's medical history, a detailed examination, and functional evaluation. During the assessment, I noted that patient had limited range of motion with pain with cervical spine movements. The patient also reported occasional numbness and tingling in her right arm and hand. Based on these findings, I suspected that the patient may have an underlying cervical spine pathology such as cervical radiculopathy. I performed a detailed assessment to further evaluate the patient's cervical spine. The assessment revealed that the patient had a positive response to centralization of her symptoms with specific movements and positions. This finding was consistent with the diagnosis of cervical radiculopathy. During the assessment, I performed a series of test movements to evaluate the patient's cervical spine. These movements included cervical flexion, extension, lateral flexion, and rotation. The patient's symptoms were reproduced with cervical extension, indicating a positive response to centralization of symptoms. The patient experienced a loss of cervical range of motion, particularly in flexion and extension. This was likely due to pain and inflammation of cervical spine. We worked on improving her range of motion through gentle mobilization technique and exercises. Centralization and peripheralization are important concepts in McKenzie method. Centralization refers to movements of the symptoms from the periphery, such as arm or hand, towards the center of the spine. Peripheralization refers to movements of the symptoms away from the center of the spine towards the periphery. In this case, the patient experienced centralization of the symptoms with cervical extension exercises, indicating a positive response to treatment. The patient reported a decrease in pain and increase of range of motion during the test moments. After several sessions of treatment, she reported significant improvement in her symptoms, including reduced pain, increasing range of motion in her thumb and wrist. She was able to resume her activities of daily living without difficulty. I initiated a treatment plan which included directional preference exercises and postural correction. The patient was also educated on self-management strategies such as ergonomic modifications and home exercises. Directional preference exercises are a key component here, which focuses on identifying movements that either increase or decrease the patient's pain. In this case, the patient's pain decreased with cervical extension exercises, indicating a directional preference for extension. These exercises were performed in a controlled manner to avoid exacerbating the patient's symptoms. Postural correction is essential in management of cervical radiculopathy, as poor posture can exacerbate the symptoms and contribute to functional impairments. I educated the patient on proper posture and body mechanics, and we worked on correcting any postural abnormalities during our session. The patient was instructed to maintain a neutral cervical spine posture during activities of her daily living and avoid prolonged positions that increased her symptoms. She was educated on proper ergonomics and workstation setups to prevent increase of her symptoms. Over the course of few sessions, the patients reported significant improvement in her symptoms, including reduced pain and increased range of motion in her thumb and wrist. As the patient continued with her physiotherapy sessions, her symptoms continued to improve and she regained full functions in the thumb and wrist. I maintained regular communication with the patient's referring physician, who agreed that patient no longer required surgical intervention for Quervain's Tenosynovitis. The patient was discharged from physiotherapy with a home exercise program and instructions for ongoing self-management. This case highlights the importance of thorough assessment and consideration of differential diagnosis in patients with musculoskeletal complaints. The use of directional preference exercises and postural correction, along with education on self-management strategies, proved to be effective in managing the patient's cervical radiculopathy. The use of directional preference exercises and postural correction, along with education on self-management strategies, proved to be effective in managing the patient's cervical radiculopathy. The patient reported significant improvement in her symptoms, and we were able to achieve centralization of the symptoms with specific movements and position. This case highlights the importance of thorough assessment and individualized treatment plan in the management of cervical radiculopathy. In this case, pre-rehabilitation of Quervain's Tenosynovitis led to correct diagnosis of cervical radiculopathy, allowing for targeted treatment and optimal outcomes. The McKenzie method was instrumental in guiding the diagnosis and treatment plan, ultimately improving the patient's quality of life.